Welcome in, everybody. We'll be starting the webinar here shortly. Just going to wait for some more people to come into the room. Welcome to the webinar, everybody. Going to get started here in just a couple of minutes. Just going to wait for a few more people to get here. Once again, welcome in, everyone. We'll be getting started here in just a minute or so. Okay, it looks like we've got quite a few people in here, so we'll go ahead and get things started. Hello, everybody. Welcome to the webinar Diagnostic Hand Ultrasound Part 1, Introduction to the Dorsal Hand. My name is Chris Pennell, and I'll be moderating today's webinar. This is the first webinar in a four-part series on the hand, and you can sign up for all the next parts of this webinar series on sonosite.com/behind-the-scan webinar. All of our previous webinars are available there as well, so feel free to take a look at our archives for even more educational material. Before we begin, please be advised all attendees are muted. We'll be conducting a Q&A session at the end of the presentation, so feel free to send those questions in while the presentation is going, and we'll be sure to get to those at the Q&A session. If you're on the Zoom stream, you can type your questions into the Q&A box into the toolbar located at the bottom or the side of your screen. And for our viewers on YouTube and LinkedIn, you can enter your questions in the chat box and we'll get to those. This webinar will be recorded and archived for future reference on our webinars page and on Sonosite Institute. Here with us today, we have Daniel Shelton. Daniel is the Director of Musculoskeletal Market Development for Fujifilm Sonosite. Daniel has spent 19 years as a dedicated musculoskeletal sonographer, and 14 of those years have been here at Sonosite. He now leads a musculoskeletal market development, where he works to spread the word about the benefits of point-of-care ultrasound. And with that, I'll hand it over to Daniel for our presentation.
Thanks, Chris, for that introduction. I'll go ahead and get started. All right, let's get started with this ultrasound of the dorsal hand. And to kick it off, here are some list of indications from the AIUM website about when ultrasound is indicated clinically for the hand, although there are lots of other uses we'll talk about later, but these uses typically include inflammatory arthritis, that can be effusion, synovial hypertrophy, or hyperemia or bone erosion. Now, these are mostly for rheumatological applications, and we'll have a webinar dedicated to that as part 3 of this 4-part series. So make sure you join us if that is your topic of interest to focus on arthritis, ultrasound of the hand. Also, tenosynovitis, I think, concerns everybody, whether it's the arthritis community, sports medicine, pain management, and acute injury back to sports, ortho, I think of hand surgeons, highly specialized topic there. Again, this is part 1 of a 4-part series, so make sure you're joining us for part 2, where we flip over and go to the volar hand. Part 3 will have a guest speaker, Dr. Dan Malone, rheumatologist out of Madison, Wisconsin, as he discusses the arthritic hand ultrasound protocols. And then part 4, the advanced hand ultrasound. This list will probably change a little bit, but we'll be covering the more extensive ligaments that are tricky, more advanced scanning techniques, some of the advanced anatomy that are more complexes, where some of these tendons are coming together, like the extensor hood, and even the tendons around the knuckles, where you end up with these musculotendinous junctions out of the palm of the hand that go to form the tendons over the dorsal part of the finger knuckles and aid in flexion and extension. So we'll be covering those in the advanced webinar, as well as the thumb as a complex. We'll be covering this big deep dive on the thumb because the thumb is very complicated and goes in all directions and has a crazy amount of tendons and ligaments that are commonly injured. Uses of ultrasound, as we mentioned, arthritis, but joint infection, solid versus cystic soft tissue masses, I would say is a big one. Whether it's a ganglion cyst, is it compressible? Is it something that's old and solid? Can we tell that with ultrasound? Yes, you can. Anatomic variants are big, especially if you're looking at hand for surgical planning. You can check out some of the variant tendons for donor ligament sites, for example. We won't be showing pathology because of the limited amount of time, but take a minute and look up boutonniere deformity, swan neck deformity, and mallet finger. Those are very common injuries of the finger that are viewed with ultrasound. You can see fractures really nice with ultrasound. It does take a bit of patience, and there's a learning curve because of there are some bony areas around the hand that can look like a fracture. So it's nice to have ultrasound to compare to the neighboring finger, for example, because of the little tendon insertions can have bony ridges. And if you slice the bony ridge obliquely, for example, it might look like a fracture. So we'll go over that in the scanning techniques, particularly on the volar hand, part 2. And then compression neuropathies. We can talk about nerves. We can scan a little bit of nerves today, but we're not going into a deep dive on nerves. That'll be more advanced. Fracture healing and non-union. Ultrasound's excellent for that. Pediatric hand trauma. I mean, kids aren't going to stand still or sit still for that matter, and they're sure not going to sit in an MRI for you. So depending on the age, ultrasound is definitely more preferred than an MRI when it comes to imaging the soft tissues of the hands. And we already talked about sports injuries, tendon, and tendonitis. Let's start with bones of the hand. We're not going to make an exhaustive list of ultrasounding each one of these bones. I more or less just want to show you how to troubleshoot and navigate imaging around the bones. They're landmarks and windows and useful and helpful landmarks for isolating muscles in this particular webinar. But just as a review, and you should have seen this on the wrist webinar. So if you haven't gone back and looked at the dorsal wrist webinar, go ahead and take a look at that. But we'll do a broad overview here today. So we've got the radius, which is on the thumb side, and the ulna. And then you have your first carpal row, and then your second carpal row, or distal carpal row. And then we get into the metacarpals. There are 5 metacarpals. And then you have 5 proximal phalanxes, or phalanges here. And those are the parts of the finger that you can see. And these are the parts of the finger inside the hand, like the palm of the hand, that you can't see. Now, middle phalanx, you'll notice we only have 4 of those. The thumb does not have a middle phalanx. And distal phalanx, the thumb has a distal phalanx. So when we're naming joints, we're basically describing the union between these 2 bones and their gaps. So we have metacarpal phalangeal joints, which are the joints between the long bones inside the hand, around the palm of the hand, where you don't see the fingers quite yet, and where they meet up with the proximal phalanx, we would call that the metacarpophalangeal joint. Next, in the thumb only, we have the interphalangeal joint because we have 2 phalanxes, but there's no middle one. So we're not going to call there's no proximal, no distal. There's just these 2. So this is the only IP that we have here. So this is the IP joint of the thumb. And then we have the proximal interphalangeal joints, or the PIP joints, and the distal interphalangeal joints. Inter just meaning between. Phalanx, phalangeal, so distal most joint on the phalanx. And then when you're imaging these, you're basically you're going to be using the acoustic shadow of the bone. So in this example, we have the probe over here over the bones. The dot, you'll see I've got it correlated with the logo on the upper left part of the screen. And we've got the second, third, and fourth. So here on the bones, we've got the second, third, and fourth in the windows here. And then to scan bones in cross section, I think is the most useful to establish your landmarks. You'll be scanning proximal distal to evaluate not only the surfaces of the bone, but you're really using it for landmarks to isolate muscles, tendons and their path, even nerves. So we're not going to exhaust the list of these bones. We're not going to ultrasound all these bones. I just want you to know how to ultrasound the cortical surface for landmark targeting particularly, and even fracture identification later. As I mentioned, windows, for example, on this slice here, we've got the second metacarpal and third metacarpal, and that leaves a gap between them. So we have that gap here, and that gap is filled with muscles we'll talk about later. But here's the second and third. They do cast these acoustic shadows we can't see through bone. This is the hard echo, a hyperechoic cortex, and then you can see because it's pretty level with the transducer surface, we have reverberation. We'll see that on the long axis of the bone here pretty soon. So going a bit long axis over a really common site for hand ultrasound, hand arthritis, is the first CMC joint. So we'll just use that as an example here. The first of the carpometacarpal joints, and there's 5 carpometacarpal joints. The other 4 are just plain joints. They only have basically one direction of movement. They're pretty boring, but the thumb is really interesting. So if you get a chance to ultrasound even your own thumb, you might notice you have osteophytes or bone spurs in these joints, just depending on your life experience. But ultrasound this on all your patients for practice and just look at the variability of the joint spaces, the bone spurs, etc. But the thumb is extremely complicated, and in the advanced part 4, we're going to be going over all the ligaments around the thumb that make it tricky to ultrasound, and the tendon insertions individually, and the variants of those insertions that you might come across if you find yourself scanning the tendons around the thumb and get a little lost. It might not be that you're actually lost. It might be that your patient has some variant anatomy around those tendons. So we'll talk a little bit about those. But the thumb is a saddle joint. It does have flexion extension ability. It does have abduction and adduction ability. But this is the long axis of the base of the first metacarpal, trapezium, scaphoid, and distal radius. Moving down the thumb a little bit further, just as an example for the long bone, we have a first metacarpal, and earlier I mentioned the reverberation. So are we seeing echoes below the bony surface here? No. Anytime a hard specular reflector like cortex becomes level or parallel with the origin of the ultrasound source, the footprint of the probe, the echoes will bounce back and get kind of trapped in this hallway of mirrors of intensity of the return of the echo. So this is just a reverberation of the intense echo that's returning back at about the same intensity as it was sent out. As that bone tilts away from the probe, the echoes would reflect back weaker, and we wouldn't get this parallel line underneath the bone. We would just have the shadow cast because the echoes would reflect off a different direction. So when you're scanning these long bones in the hand, keep in mind that you're not seeing through the cortex. This is not something down the center of the bone cavity. You're not seeing any echoes inside the bone there. For that matter, though, if there is a bony disruption or a periosteal lift here, you'll see a blister on top of the bone, and we'll scan the hand on the live demo and just kind of show that what periosteum looks like. It's just a hypoechoic envelope around the bone. You shouldn't see it in normal applications, but sometimes you can. All right, so let's go to the live demo. Just scan around some of the bones, just get familiar with the shadows that they cast and the various landmarks and the behaviors of the bones as we scan them. All right, so let's see. Okay, in the live demo portion, we'll be using 2 of the main transducers. We've got our larger linear, this is the 15 to 4 megahertz linear, which is probably the most common transducer people purchase for MSK. So that's the transducer that's used throughout a lot of the presentation for the wider angle or the wider field of view, so we can catch more of a panoramic of everything that is in the hand all at once. And then the other transducer that we're going to use and kind of debut a little bit today is this ultra high frequency 46 to 20 megahertz transducer. So this is the highest frequency transducer on the point of care space. And you can see that the footprint's pretty small. So keep that in mind. The field of view is going to be a little bit different, but there is something different about the head of the transducer. You'll notice a concavity there. So the face of this transducer is built just a little bit different, and it allows us to catch very extreme detail in the near field. Penetration, though, is where it suffers. So the higher the frequency, the lower the penetration. And then the lower the frequency, the more penetration we get, but less detail. So, you know, it would be the dream of anybody in ultrasound to have a super high frequency transducer that could still see a shoulder, but that's just not the case. So this is more well suited for hands. Part parts of the foot and ankle, pediatrics in particular, this amazing transducer, things that would typically be frustrating to see on normal patients for how small it is, or maybe even small and frail with all the, like I think of arthritis ultrasound in elderly patients with really bad arthritis in the hand, and how much air gets between your transducer and your skin while you're scanning, for example. That transducer is going to be great for those that are really, really small and petite and have basically no fat. So it's just usually that would be annoying to scan with a larger transducer. But if you do have the smaller footprint probes with higher frequency, I think you're really going to enjoy the UHF 46 today. So starting out with this survey of the bones, as we did on the PowerPoint, we'll start off with the long bones. So that's that first metacarpal. If I back up approximately just a little bit, we can see the first CMC joint, which is, you're going to find a lot of osteoarthritis in here. This is a ligament. Ligaments cast shadows. We did cover a little bit of the CMC joint in the dorsal wrist webinar. So if you didn't catch that, remember, go back and catch that. We'll be covering that more in depth on the dorsal wrist. I'm going to go short axis across here, and you'll see that just to keep it consistent, I think we'll flip the notch side of the probe ulnar, and we're right up here on the far radial side of the radius. So we'll be going kind of counterclockwise across the top of the wrist like this to stay consistent with how the slides are presented today. But you can see these big air gaps on the side. That's basically the lack of transducer contact. So if you're new to ultrasound, these over here are just air gaps where we don't have any gel contact, basically. And if I wanted to just focus on the center of this picture, I could zoom in or just add a little bit of gel on the sides to capture some more image. But this is cortex of the radius. This is the first compartment. And if I fell off the radius in short axis, we'd hit the first carpal row. So we know that's scaphoid. And we could work our way up to the trapezium and then the base of the first metacarpal. So it's all about just counting your bones by seeing the joint gaps show up. I could keep following this first metacarpal distally, 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 until we come across another bone, and that would be her proximal phalanx of her thumb. As I go more midline, I like to use the bony shadows of the metacarpals as a landmark, and then come over here to that first web space. So I can see the thumb over here. So that's our first digit. Then we have that big web space in a muscle that we'll get to. And then we have the second digit casting a shadow here. So that's just how you count. So it'd be 1, 2, so second digit, third digit, fourth digit, and we got to add a little bit of gel. Gel makes everything better. There we go. So back to counting again. We've got first digit was off screen. Here's that first big web space, second, third, fourth, and then finally the fifth. And you're going to use these web spaces throughout the hand exam to evaluate which group of muscles we should be seeing. You'll notice my very, very light transducer pressure because we have these veins subcutaneously up here that we're not collapsing. So if I was looking at somebody else's images, I could tell if they were compressing. If I don't see a little bit of air gap on the sides, it tells me they might be compressing a little too much. And if I don't see these little veins patent, then somebody might not be seeing the pathology that they're looking for, because you could be collapsing things like soft tissue masses or joint effusions if you apply too much pressure. So just a little scanning tip there. And then we'll be going later towards the end of the presentation. We'll spend quite a bit of time at the knuckles. But when we're seeing two bones come together, like this MCP joint, we'll get to that. Keep in mind that the tendons are going to cause kind of an air gap sometimes if you fall off the sides like that right there. And you just want to fill that in with gel. And then what I like to do is hang a finger down. And we did this quite a bit in other webinars, like in the ankle. You'll hang a finger down, and I stick my finger right in the interdigital space, and then just slowly float the probe down in the gel. And it gets you that really, really pretty gel heap right here. And that also ensures me that you're not collapsing synovial tissue here. You can see that vein up there that's still patent. So you're not compressing things that you might be looking for. Going cross-sectionally, same thing applies. If you end up with these air gaps, you're going to fill them with gel, and you don't want to compress too much, or you might get rid of some of the soft tissue structures that you're looking for. We'll go back into the intermetacarpal spaces so we could count those out just the same as we did the webs. If you get lost, you go towards the web, and just keep in mind that these aren't fluid collections here. These are not bursa. These are just muscles beginning and going into the web space. And we'll get into which muscles those are, I think, here next. So use the web spaces to count in the hand. That helps a lot, especially when we get into these intrinsic muscles. And especially when we go to start counting which tendon is which and going back into the wrist. And then when you leave the wrist and you come out into the hand and you feel like you might have gotten a little bit lost on which digits you're in, just parking it back over to home base. Keep the left side of the screen will be, yeah, left side of the screen will be ulnar in this case. So we've got that first, second, third, fourth, and fifth. So not a lot to belabor on bone ultrasound around the hand, except when you're looking for fractures, especially in long bones. Keep in mind you're scanning a cylinder, so you don't want to pan the transducer straight across the bone. You want to aim to the center of the cylinder. So like in this case, I've got a nice bright hyperechoic cortex of the second digit. As I go on top of it, I want to aim back to the middle. As I go across towards the thumb, I want to aim back to the middle of the digit. And you have to maintain that perpendicularity all throughout your evaluation of these long bones. So they are cylinders. You just want to aim to the middle of the cylinder when you're evaluating a bone. If not, if you cut a bone a little bit oblique, you might cause a little bit of a ridge kind of looking artifact at the superficial surface right up there. You might call that something like a fracture if you're not careful. And then always compare. Keep in mind that we've got these other digits to compare. All right. So with that, we'll just go ahead and go to the next part. You get us queued up for the next slides. Okay, so we'll get started on the muscles of the dorsal hand. We're not going to cover all of them in great detail, all the muscles in the hand, but we will start off by looking at the deeper ones as a landmark. So we're not here to evaluate the deeper muscles. This is the adductor pollicis. So this is a big transverse muscle across the palm. So here we've got the probe on the back side of the hand, top of the metacarpals, and we're imaging through the metacarpals so that you see bony shadows right here. And that's what we have here, second and third. And they're casting a shadow over this transverse muscle. That transverse muscle is a great landmark for this particular presentation. We're not studying the adductor pollicis in this axis. On the next webinar, the volar hand, we'll go over adductor pollicis anatomy, and it's in pretty great detail. But for today, we're going to use it as not only a landmark, but a backdrop to these other more important muscles on top. But it is a great place to start, almost like a home base in the hand if you get lost, or if you're just trying to find your way around these other muscles. The adductor pollicis is a great landmark. Going further into the palm here, slightly more ulnar towards the pinky, we have the shadows cast of the third, fourth, and fifth metacarpals. And it's easier to see what are called the lumbrical muscles of the hand as a landmark only. Again, this is not us studying the volar hand, but these are great landmarks to tell you when to stop looking at some of these other tissues. So screen left over here would have been more adductor pollicis, right? But as we climb more over towards the pinky, we have these other muscles that we're going to talk about, but you need to know when to stop looking for the muscles and when to expect other structures that are making up the backboard of your image. So down here, this would be the palm, the skin of the palm right here. And then you got your flexor tendons that go to the tip of the fingers. The deeper flexors have muscle bellies hanging off the side of them. And those are called lumbricals. And those are just a landmark for the dorsal hand. And we're going to be more concerned about these other muscles next. So getting into those more important muscles. All right, so we've got second, third, and fourth metacarpals here, second, third, fourth, and you can see the flashing anatomy over here. I made these blink because some of the anatomy looks redundant. It looks like it's just a layer repeating on top of itself, but it's not. These are the palmar interosseous. They're responsible for the abduction, abduction of the fingers. Does help the lumbricals with flexion. And think of pad. So this is palmar adduction. So palmar interosseous. There are three of them. You can see them blinking over here to the radial side, or sorry, the ulnar side of the second, and the radial side of the fourth, and the radial side of the fifth. All right, so now the dorsal interosseous. These are a little bit more important, easier to see. They're more superficial, going back over to the adductor pollicis, which is right here. We can see the adductor pollicis through the transparent layers here, and we started out with the adductor pollicis as that big transverse muscle. So in that first web space, we've got the thumb. Way over here, this slight shadow, we've got the thumb casting a shadow of the first digit. Then you have this big web space between your first digit and your second digit, and that's what we're looking at right here is that first dorsal interosseous. You can see that one head of it starts on the thumb and the other head of it starts on the second metacarpal. We're going over to the next web space where you can see the second dorsal interosseous, and it starts on each side. We've got the one head of it starting on the second, one head of it starting on the third, climbing up to the middle finger here. And then on the opposite side of that, if the probe were moved over, it would just be a repeat, but flip the other way. Basically, we would have the dorsal interossei of the third and fourth heads coming up to attach on the ulnar side of the middle finger. And it should be noted that these tendons extend on to become part of the extensor tendon complex on top of the fingers. We'll talk about here in a little bit. And they also contribute fibers to the sagittal band, which we'll talk, or the to the dorsal hood, which is kind of an extended exam past the sagittal bands of the finger that we'll talk in great depth on part 4 on the advanced hand. So we'll go down sagittal band, dorsal hood, and then these fibrous connections and contributions from the interossei and the lumbricals that come up and attach to these tendons. So don't forget to join us in that webinar. Now think of DAB. DAB. So the dorsal is responsible for abduction, and there are 4 of those. All right, so off to the pinky side, there's this big lump of a muscle. It's not one of the interossei, and it's not a lumbrical, so it's kind of off on its own. And the small digit, the digiti minimi. So there's a whole group of these muscles that we'll talk about, and they're all referred to as digiti minimi. And here we've got abductor digiti minimi. It originates from the pisiform. I can't say that I was super well versed in this muscle going into this presentation. I've always just looked at the muscle belly and its tendon, but not really its origin so much. So I did go ahead and put those in my notes here. So we've got origin of the pisiform, insertion, the base of the proximal phalanx, and it's shared with the flexor digiti minimi. And it sends fibers to the ulnar lateral band and extensor hood of the 5th digit, and it functions to help with the MCP joint flexion and PIP joint extension. Now let's go ultrasound those intrinsic muscles and make them move with the live demo. All right. So we've got same linear array transducer we'll start with. And then on the next part of the exam, when we get into these extensor tendon compartments, we'll switch over to our smaller footprint. But this is more of a survey approach through these muscles of the hand as we started out in that first web space. Now we can explore that first muscle belly that we looked at earlier. So we've got, let's find our deeper landmark, that pollicis. So I've given myself a little bit of depth here on the machine, and that's that abductor pollicis right here headed towards the thumb. If I followed that anatomy diagram, I would actually spread the thumb a little bit like this and stretch it out. So if you don't get that nice striated pattern, just try having them do the function, the abduction there, and you'll see that nice striation there. So we're focused now on this superficial group here. So I'm going to go more shallow. And that's our first dorsal interossei. So we've got that more thumb first metacarpal head that starts right up against the inside of the first metacarpal. You can see that belly out. And as a landmark, it's kind of cool. There's this neurovascular complex from the radial that comes up from the palm. So that is the radial artery branching to become dorsal, and it wraps around the thumb right here. So it's the perfect dive straight up and down. And then this is the second metacarpal head of that first dorsal interosseous. But if we wanted to put color on that, I think it's very helpful to just say, hey, that's not a ganglion cyst or something. We could open the color box and just show that that is just a fluid collection. Now the little dots next to that are not showing flow, these are nerves. And we'll get into that with the part 4 webinar on the more advanced hand structures. We'll get into neurovascular structures, but let's keep following that dorsal interosseous. So we've got second metacarpal. I'm all the way back here at that intermetacarpal row. If I were to go a little bit more proximal, I'd be at the distal carpal row here. So first row of metacarpals, far radial side, we've got the thumb. Here's that going to the pointer finger, the second finger, and you can see the origin of that interossei muscle right here, this head. And you can see those two heads from the illustration diagram come together right here. Boom. So there they meet, and then they head over to the far ulnar side of the second digit. So they become this kind of common musculotendinous muscle. And then we start to see these flat kind of facets of the distal metacarpal head. And that's where our collateral ligaments are diving. So these dark shadows that we're seeing are the beginning of the MCP joint. So if I were to keep following that, you would see that the tendon, let's follow this bright stripe in the middle, the tendon of the dorsal interosseous becomes one of these dark shadows on the side of what is going to be called the sagittal band. And we'll get into that in the advanced webinar, but that's where you would start tracing it as it dives to go inside part of the sagittal band. And unless they have symptoms to go any further, just like in the shoulder, you would stop scanning a biceps at the pec or other structures in the body where, you know, you don't have to go out to their terminal ending. This is a good place to stop because we're looking at muscle quality here for atrophy. And then I'll go over here to the second web space. So we're in the second web space now. I can go back to the proximal portion again. And you can see the two heads start right across the top of those base of that second and third metacarpal. We can see the heads of the muscle begin. And same thing, there is a little artery that pokes out from the palm of the hand and makes its way dorsal. But we'll follow that muscle belly just straight on to the end. And remember that backdrop right there. So we still see the pollicis down here, that abductor pollicis, as horizontal, or at least we'll see it behind the second and third. But remember, it attaches to the third, so we're not going to see it beyond that. Over here would be purely dorsal interossei here and palmar interossei. So we get those two layers right here. But here's that pollicis right there. So dorsal interossei here, palmar interossei, and then here's that abductor pollicis. And remember, we can shoot all the way to the table in the hand. So that's the table down at the bottom. So we're getting a cross section through the whole hand. And here's the flexors. So that's the first flexor, or you could just call it the pollicis. So that's flexor pollicis longus right there. Here's the flexor tendon to the second digit, which is here. Flexor tendon to the third. And it's just really neat to me, especially on the palmar side. This will be a lot more pretty to look at these muscle bellies, but just as a landmark, you can see a superficial or close to the table flexor and a deep flexor. So you can see those two stacked on top of each other before they reach the knuckle and become, you know, those areas in the A1 pulley where we look for trigger finger and stuff. So you could see the muscle belly kick off the side of that just as a landmark. That's a lumbrical. And when we get to the volar hand, we'll evaluate those in a lot more detail, do some dynamic maneuvers. But just as a landmark on the dorsal hand, we can see I don't need to be looking for interosseous structures past this fascial plane of the lumbrical and that flexor tendon. So I can just stay in this area here and not worry about going any deeper. And that's one big benefit of having a larger footprint transducer for this particular exam. When we get to the rest of the wrist tendons going out to the extensor mechanisms of the fingers, we're going to switch to the small footprint transducer for sure. But just following across these rows again, just going in between the spaces, looking at the dorsal and palmar interossei right here and here. Dorsal. So we do have a dorsal interossei in each web, but we don't have a palmar interossei in every web. So in the middle finger, they're skipped. So palmar interossei not involved in the middle, but dorsal, everything leans towards the middle finger for dorsal interossei. Everything goes away from the middle finger for palmar. So you don't even want to look for palmar interossei in the middle, but you will look for palmar interossei on the surrounding fingers. And then way over here, pinky side, you can see that digiti minimi muscle over here, just as another landmark. Not one of the interosseous, not a lumbrical. It's kind of its own thing. And it becomes a part of that same extensor tendon hood complex that we talked about a little bit. Now, this was not in the slides, but I do think it's important to do. So you do need to get these images in two planes. So as a landmark, we have the first web space here, and I'm just going to fall off the second metacarpal until I see these muscles here. So superficially, first off, let's go screen left is proximal, screen right is distal. So you can see that MCP joint that we looked at earlier. I'm just going to fall right off of that. And you can see the dorsal interossei muscle heads right here. So we got muscle, tendon, and then remember that we have a long axis dorsal interossei. Now we have a short axis abductor pollicis. So if she were to wiggle her thumb just in and out like this, yep, we're isolating that abductor pollicis right here. So if I go long axis on that, we'll see the abductor pollicis moving. Again, this is ultrasound. We make it move because the muscles may be wasted away and the margins between these muscles might not be so obvious. So you're going to want to move them in your landmark. So now I'm going to jump from that first web space to the second web space. And in the second web space, we can still see first superficially are the dorsal interossei. Now we have a palmar interossei. And now we have that abductor pollicis still sitting right here because it hasn't attached yet. It won't attach and I won't lose it until the third digit. So it's still right here. So go ahead and move the thumb again. Make it move. It's ultrasound, make it move. And then we go over to the third space and we don't see that anymore because it's attached to the shadow underneath of the third metacarpal. So always image these things in two planes if you're suspecting pathology, but use that abductor pollicis as your roadmap to get through the palm of the hand. The things superficial to it are your interossei, and the things deep to it down here are lumbricals. Right down here. So we have a flexor tendon. Remember, we're going all the way to the table here. So this is the table. This is lumbrical. This is flexor tendon. This is abductor pollicis. This is dorsal interossei. And palmar. So keep in mind the metacarpals are your roadmap, and so is this big abductor pollicis guy in the middle. All right, so now we're going to move over to the extensor tendons. So let me get that slide queued up and we'll get going. Okay, let's start ultrasound of the dorsal extensor tendons, and there's lots of them. There are 9, 6 compartments over the wrist, and then we'll watch them branch out to their various insertion trajectories. We're not going to ultrasound these all the way to their enthesis. We'll do that in the advanced webinar because some of them blend out to be more complicated structures over the knuckles. But for today, I think you should walk away with quite a bit of confidence when it comes to tracing out these tendons and their variable anatomy. So if you didn't catch how this pertains to a wrist exam, like arthritis, synovitis, the carpal bones of the wrist, go back to the dorsal wrist webinar and review that. Today, we're not going to be covering these ligaments around the wrist or the wrist recesses. We're just going to do a review on how to find these extensor tendons in their various compartments so that you can use the compartment as a landmark to track them out and eventually see them over the more relevant anatomy in the hand. So just as a review, we've got this wrist diagram over here on the left, which is great. And then we have this example MRI on the right. of the compartments in cross section. So we should see something like these shapes when we start ultrasounding, but I did want to share a helpful mnemonic that's always helped me. It was taught by a radiologist that I used to work under. It's very helpful for me to remember. So basically, if you're starting over here at compartment 1 and working your way to compartment 3, that's where this mnemonic is going to help you. So all peanut lovers eat peanut butter. So if you can just remember that phrase, it's a good way to kind of kickstart your wrist exam in compartment 1. And after that phrase, these just alternate. So they go longus, brevis, longus, brevis, longus. So all peanut lovers eat peanut butter. Then you've got your ECRL, ECRB. So it just keeps alternating until you get to extensor pollicis longus. And then over here, there's some neat variation of the scanning planes that it takes to see the difference between extensor digitorum communis and indices. Think about index finger indices. This is another tendon going over to your pointer finger. And then in extensor digiti minimi. So we talked earlier about what digiti minimi means, small digit, so you can only guess where it's going to terminate. And then extensor carpi ulnaris, which is more of a wrist exam, but it does technically insert on the base of the fifth. And we'll talk about that because it inserts in the hand. So here we've got the all peanut lovers. So we've got the APL, the abductor. So abduction is bringing away from the body. Think about abduction in the shoulder. Pollicis means thumb. Longus. So abductor pollicis longus and extensor pollicis brevis. So that's those two tendons here in the thumb. And then they have their own individual retinaculum and they share a common tendon sheath here. Here's the ultrasound distal radius. Dorsal is marked here, volar is marked here. There's a little vein up here that's compressible. It's a good landmark. And then you have an artery, the radial artery on the volar side as a landmark. So EPB and APL are here. Not reading from left to right, but right to left. We're going to go counterclockwise around the wrist. So all peanut lovers eat peanut butter. The APL is the bigger of the two, and it's got variable branches of tendon insertion. We like to think it's always going to insert right here on the base of the first metacarpal, but that's not always the case. And we'll do that in our live demonstration because our model does have variant anatomy with multiple tendon insertions of the APL. So you'll get exposure to that today. Extensor carpi radialis longus and extensor carpi radialis brevis. So this is your alternating. We went from all peanut lovers eat peanut butter. So now we're back to longus brevis, right? So ECR B and ECR L. And then they have their own retinaculum and tendon sheaths. I say sheaths because there are two here. But we're going to find those and isolate the base of the second and third metacarpal and be able to ultrasound these tendon insertions really, really well. There's also some anatomic variation that people can have down here at the base of these metacarpals that can hang down as a big bony prominence. Might just check out from a pathology standpoint or just something that's for troubleshooting carpal boss. And you'll see some variation of what the anatomy might look like down there. Here's the ultrasound. So we've got ECRL. Again, we're going counterclockwise here. So we've got longus brevis because up here in the third compartment, we'll alternate back to longus. So we've got ECRL, ECRB, and here's the highlighted compartment and its own retinaculum here going long axis. Again, we went into a pretty good deep dive around these compartments on the dorsal wrist. Then we have the extensor pollicis longus. I think this is the most fun to look at because we have this cool landmark called Lister's tubercle on the top of the wrist. You should be able to palpate. Then if you just wiggle your thumb, you'll see this tendon move. So it's a very small tendon. It does jump up and over compartment number 2, so ECRB, ECRL, and there can be intersection pathology that happens there. There can be rubbing tenosynovitis that happens there. So take a look at that in the anatomic snuff box that's formed in this triangle, and you might see some pathology right there. It does have its own retinaculum and tendon sheath. Here's what it looks like on ultrasound. You can see Lister's tubercle, that high prominence. You should be able to palpate that right on the slight thumb side of the midline of the top of your wrist. And then count over from the ulnar side, you should see compartment number 3, this little bitty strap here. Compartment number 4, if you wiggle the fingers, you'll see compartment 4 move. The number 2 doesn't move a lot for you. If you're holding the wrist still, you'd have to do some abduction maneuver there. And but wiggling the thumb highlights extensor pollicis longus really, really well. And another way to highlight extensor pollicis longus really, really well is to use an ultra-high frequency transducer. So today we'll be scanning a little bit with the UHF 48 from the Sonocyte LX system, where we can see these tendons in great detail, and there are variations. I will say that being able to see anatomic variations with such a high frequency clears them up completely. So you really, really know just the normal anatomy versus people with anatomic variation really, really well. And we'll get to that when we get to Digiti Minimi as well. So this is an example, a video clip of the extensor pollicis longus. It's muscle belly. As we wiggle the thumb, you see the muscle belly. It's not fluid. Some people might call that fluid. With a lower frequency probe, it may not highlight as well. And then also take a look at the space between this third and fourth compartment. You see this little bright white triangle. This little fatty triangle contains a nerve. For the advanced webinar, which we can cover a little bit, it's more of a wrist structure than anything, but that's the distal branches of that posterior interosseous nerve sitting right there in that triangle. Okay, back up to the extensor digitorum communis. Okay, so that insertion is right up here, way at the tip of the finger, and you've got a central tendon slip inserting right at the PIP joint, and we'll cover those in the last part of these slides. And then it's got a neighbor. So I'm going to go back and forth, just to show you what we're looking for here. So there's an ulnar-sided muscle that jumps off the ulna, goes under extensor digitorum, right there, and joins the second metacarpal pathway of extensor communis. So the second extensor communis tendon, you'll follow that extensor tendon just like you would expect to see it. But if you're counting these bundles here, you'll count 4 bundles of tendons, and you might expect 4 to go to 4 fingers here. And for some people, that's true. Some people are going to get a 4th one to go out to the 5th digit over here, but it's really the 2 of them shoot off and follow the second metacarpal, which is really, really fun to kind of train your eye to pick up. So they also share their own retinaculum and tendon sheath. And here's what they look like on ultrasound. But if you wanted to isolate the indices, think about index finger indices. So communis is more of a common tendon with these 3 digits here mostly, and sometimes 5th. But we're really looking at this extensor digitorum compartment of compartment 4, and there's an indices layer. If you were to just wiggle the pointer finger, you would see it isolate and trace that proximally into the muscle bellies, and then go distally and see what you find. Extensor digiti minimi. We've hinted at this a couple times. Where would it eventually go? So small digit, digiti minimi, and we could see it over here. And it does have a lot of variation. So I've seen this not have a branch and it just kick off one tendon. I've seen it kick off tendon over here to the 4th digit, which we have, I think, in a variant anatomy in our model today, where there's a teeny tiny offshoot that actually goes and communicates back into the 4th. And then there's others that can have up to 4 or 5 tendon slips that wrap around the knuckle here and eventually become a part of that dorsal hood complex that we'll cover in the 4th webinar. But just be aware, this is a pretty fun site to learn about anatomic variation, watching this tendon split. There is some variation between the extensor digitorum communis, the 4th digit that will jump over to the 5th. I actually have that in my hand. In my hand, it shows up really nice. So I might plop the probe down at the end for Q&A or something, just to show the differences between our model, that we have a tiny cord offshooting from here, where it looks like it's most people's, it seems to bifurcate here, this tendon. On our model here today, there's a trifurcation, basically. There's a teeny tiny cord that goes right up into the 4th and combines with the dorsal hood here. And then there's a variant retinaculum. Our model has it, I have it. I'm not sure how variant it is, because when you look into it, there's 71% will have another little retinaculum that hangs on to the extensor digiti minimi right here. And it kind of looks like it adds like a pivot point to go over here to your 5th digit. And here's the ultrasound. So we've got the probe placement here, compartment number 5. So you should just be able to lift the pinky and get this guy to wiggle around and see it. And then we'll trace it out distally, but on the ultra high frequency 46 megahertz transducer, we can see those 2 branches already here, where in here it's kind of averaged together. So you have what's called volume averaging, where we can't resolve certain things at certain frequencies because of the thickness of the ultrasound beam, and we've got very little of that happening here, where we can see these divisions very nice. All right, extensor carpi ulnaris to wrap up the compartments. It does insert at the base of the fifth. It's easy to find. It jumps over the TFCC, which we covered in the dorsal wrist webinar, so we're not going to go over that again, but we will cover the tendon and thesis here. And it does have its own retinaculum and tendon sheath. Here's what it looks like on ultrasound. Just like the other compartments, it's got its own strap that holds it down. You might look for erosions here. This is a pretty common spot to look for erosions in rheumatology. We'll get to that in webinar number 3. And here's what it looks like on our ultra high frequency 46 megahertz transducer. So you could see it just fine at 15 megahertz, or just fine so you thought. You might catch a lot more intrasubstance detail here if you're studying more detailed anatomy for particular procedures, precise needle placement, etc. I think 46 megahertz has a place to play here. All right, let's go scan those tendons, and we will show the examples of them going out to their trajectories, and we may or may not follow them all the way out to their visible insertions depending on the digit. But let me get set up for the live demo, and then we'll come back to wrap up the top part of the knuckles. All right, so we're going to get started. Just a quick overview with the larger linear as we showed, and then we're going to switch over to the 46 as promised. So here we are in the extreme radial side to catch compartment number 1. And when we're catching compartment number 1, there we go. Let the depth catch up to me here. Remember, I said that the abductor pollicis longus had some variation, and here you can already see we've got the APL and EPB separating as I leave the radius and go into the snuff box. And on our model here, we've got 3 tendon heads. We've got 1, 2, 3. Instead of it just going very simply to the base of the first metacarpal, hers actually goes extremely palmar, and there is insertions that take place at the open ends here. So we're following these heads right here, and one goes to trapezium and the other goes to the open ends. So I'm going to have her kind of go into a karate chop position just to make that a little bit easier for me and for the probe to be visualized where we're going. But there's nice variation in here to be seen. So here's APL, EPB, APL branching off. There we go. And then that one tendon head going into the open ends. All right, we'll switch over to ultra high frequency for that one. And I see that the time's counting down on me here. So I'm going to switch over to 46 megahertz for the sake of time. And I might just do the rest of these compartments at the ultra high frequency. I was going to do a comparison of the two, but I think you'll make up your mind based on the slides. They were done with the 15. So here we are, compartment number 1. Let's get a bony landmark. So we've got counterclockwise, APL, EPB, right here. EPB keeps going straight. APL dives under the palm, and there's those 3 heads right there. So we've got 1, 2, 3. 1 is more direct to the base of the first. 2 goes and obliquely starts to dive. And I'm going to rotate my transducer. You see it dive right there to the trapezium, right there. So trapezium, and then here's some muscle fibers of that open ends. And let's go back cross-sectionally and see that. Start back all the way at the compartment. There it is. So that most palmar side, here's some radial nerve branches, radial artery underneath. But we're going to follow this tendon, and you see that tendon turn into musculotendinous with the 46 megahertz, very clear. I would say it's a little more ambiguous with the 15, but you can very clearly see this tendon, this oval, branching out to the open ends. There we go. So I'm going to go back up compartment number 2. So mnemonic time, if it was longus brevis, now we have longus brevis, so this is ECR L, ECR B. So we'll follow ECR L to its insertion on the radial side of the second metacarpal right here. So that's the cross section, and everything has to be done in 2 planes.
We'll catch that in short, or sorry, long axis here. Left side of the screen will be proximal. And it's just so clear with 46 megahertz. I would say that looks like the lateral epicondyle of an elbow more than anything. If I was glancing at this as a still shot, I would say that was an elbow picture until I really started seeing that skin. But yeah, here's that radial side of the base of the second. And then we would go cross-sectionally again, find our next tendon head. So let's go back to the compartment. We've got compartment number 2. This is ECRB, and we're going to follow it to the base of the third. So here's EPL jumping over it, but this is ECRB. And then you can see it starting to flatten out, turn into a bit of a shadow, straddling that base of the third metacarpal. So that's third metacarpal. And if I were to keep going, remember you see the interosseous muscle start up. So that should be a review for you right now. So that's interossei, dorsal interossei right there. And then here's the insertion of that ECRB. So let's go back to its compartment, and then we'll jump over that landmark of Lister's tubercle. So no more karate chop there. We're just going to go straight top. I've got my finger down to the side of the patient's skin, and I'm feeling for Lister's tubercle. There it is. So here's Lister's tubercle, and here's EPL. So let's wiggle the thumb. And we can follow that wiggling thumb, this big oval of a tendon, all the way out over the second compartment tendons into the snuff box, and following the ECR or the ECRL, ECRB, and then we've got extensor pollicis longus right here. Just making it move all the time with ultrasound. Do everything you can just to make the anatomy move, and we can follow it out. And it looks like it's going to split, which is probably a variation. I didn't see that. But you'll see it not only splits, but joins up with some of the EPB. So we'll go back up to Lister's tubercle as a landmark. There it is. Now let's go to the dorsal extensor tendons right here. So this is compartment 4. And if we were to have her point her finger, we would reveal what I suspect to be indices, which is the guy on the bottom. So let's follow the guy on the bottom and see if it goes and inserts, or originates, I should say, on the ulna. Yep. So here it is. It's originating on the ulna, and she's pointing her finger, and I can see the tendon starting. So go ahead and point your finger again, up and down. Yep. And then we'll go follow that. So that's indices. The rest is real obvious. That's all communis. So if she just wiggles her fingers, we'll see communis move around. And then we want to follow those out here. Very easy with a transducer like this. Following communis and indices, they travel as a pair. This is the second metacarpal here, and you're going to see ulnar-sided communis and radial-sided, I got that backwards, ulnar-sided indices, radial-sided communis going right over the second metacarpal until they reach the sagittal band area of the metacarpal phalangeal joint. So if I go long axis just to check my work here, yep, here's the MCP joint. And if I were on the radial side of the MCP joint, I know that's communis. If I were on the ulnar side of the MCP joint, I would know that that is indices. There we go. We're up on the minute. Run flat out of time to finish all of this up. Let's go over here to the fifth compartment, which is going to rest in the radial ulnar joint space right here. So let's wiggle the finger. So here we have extensor digiti minimi. And I promised an anatomic variation here, so we're going to find it. So here's digiti minimi. You can see it start to split. And then the split will eventually go around that fifth metacarpal real nice. Let's add some gel. Start to drag the skin. There we go. Gel makes everything better. Here we go. Okay, so instead of just 2 pieces, we end up seeing this third guy right here. And that third guy or girl wants to go split off and head to 4. And that's an anatomical variant, and it may or may not influence her ability to have a tendon transfer as a ligament reconstruction. So let's follow that back. I don't have that in my hand. When I follow that little slip all the way back to the fifth compartment, I usually just see two heads. I just see two heads of extensor digiti minimi right here. And then finally, we got ECU, compartment 6. What I like about this transducer's ability to see the retinaculum with striations. I'd say that's pretty unique. And you can also see probably some septations in that tendon too. So here we are in extensor carpi ulnaris, jumping over TFCC, over the triquetrum, onto the base of the fifth. And then as we mentioned, that anatomic variant retinaculum is right here over that fifth compartment group. So you can follow that shadow out laterally. It wraps around the ECU. Chris, I know we've run out of time. I'm going to keep scanning over knuckles, but if we want to start taking some questions, we can get the Q&A teed up. I know that I've run over on time.
Yeah, absolutely. Yeah. If anybody has any questions, feel free to submit them. If you're on Zoom, the Q&A box is either at the bottom or the side of your screen. And if you're on one of the other streaming services, go ahead and put your questions in the chat box, and we'll be able to get to those.
There's just so much to talk about when you start adding frequencies like this. It's just truly amazing. So here I am back following that second metacarpal, but I've got the extensor digitorum communis and indices just bordering each other there. There we go. That's how we were oriented earlier. So screen left would be ulnar, screen right would be radial, metacarpal head, muscle bellies in the middle. We've got our, almost trying to quiz everybody here. First muscle belly, second web space. This will be the second dorsal interossei or interosseous. We can go over to the third web space. We can see the third interosseous, but way more cool to see the little neurovascular structures that are out there. And it can be a lot to take in to see that kind of anatomy. So you can activate what's called trapezoid mode, and we can make this more of a wide angle view. So let's do that really quick over the dorsal wrist compartments. So I'm just going to activate trapezoid, make this a little bit bigger picture. On the side walls, you'll notice it just got a little bit bigger. Probably not necessary to get that bright. I think zoom was a little overgained. There we go. But where there's anatomy that's typically a big challenge is just picking out these little variants of the extensor tendons, because it's very helpful when you can find a variant tendon that could be used for a tendon transfer in orthopedic surgery, like maybe an ulnar collateral ligament reconstruction on the thumb. If you can go grab an extensor tendon that's redundant somewhere, I think that definitely saves everybody a little bit more incisions in other body parts, looking for other portions. Here's a little sneak peek of the advanced webinar. We're just going to go right over her ulnar collateral ligament in the thumb. We will cover the UCL in depth on the advanced, but here's her UCL on the thumb. Let's give that a wiggle on top and see the aponeurosis move around. And still no questions, I take it. I know we've gone over on time. I want to be respectful of everybody's time.
We do have one question that just came in.
Perfect.
We have, please show us your technique for evaluating cortical fracture in either metacarpal or phalanges.
So we're going to cover that on the volar hand, but just for the people that have stuck around, it's kind of nice because not really nice, but our model here has been recovering from a volar plate avulsion. So if you go ahead and flip your hand over, we'll see that she's got a very irregular volar plate surface. I know we didn't go over this anatomy, and we will on the next webinar next week, but the bone should look nice and smooth. Let me go to the neighbor like this right here. And then here's volar plate, this homogeneous tissue here, joint capsule, flexor tendon, But the volar plate should attach here really smooth, and we shouldn't see anything floating out in the volar plate tissue. But as you're scanning for fracture, you really want to scan back into the structure, because we're scanning a cylinder, right? So I have to scan up and over and back into the center of the cylinder. Now, this was a union that started to heal up. I think the injury is 3 months old now, maybe 4. But it's been neat to just kind of follow it on ultrasound. But yeah, seeing avulsions is very useful in ultrasound, and if they're moving or not was one of the big questions the surgeon had. But yeah, we're looking at a fracture right there. I would say we're 4 months into healing, and always confirm things in 2 planes. So we're looking for a step-off deformity here. So let me go back to the normal knuckle here. So we have a normal volar plate here. I'm going to go distal, so I know I'm at the proximal edge of the middle phalanx right there. And then I'm just going to pick a side. You don't want to go dead center. You want to pick a side. And we're going to follow this lip until it reaches the homogeneous volar plate right there. Nope, I went the wrong way. Okay, so that's proximal edge of the middle phalanx. This is the homogeneous volar plate. Now let's go to the bad one. So proximal edge is here, and then we start to see these little bony flecks hanging out in the volar plate. So we don't want to see that. But see the angle I'm having to maintain so that I don't lose, 1, skin contact, 2, I want the echoes to reflect back really nicely. So I have to maintain perpendicularity to the center of the object I'm scanning. So in this case, I'm mentally just trying to aim my beam to the center of the cylinder. And to put things into 2 views, you always want to split your screen and have a 2 view in one. So left side would be our short axis view of that bony avulsion. Looks a lot better than it did 4 months ago. All the tissues are way more connected now, but you can see just how irregular that is. And then I'll go here and go long axis, and you'll see that little bony edge hanging out. And I'll hit save, and we could compare that to a traditional linear and just see what we see for anybody that's still hanging out. It looks like we have, I don't know, we still have almost 30 people here. So I'm going to switch to the regular linear while we wait on the next question. It's been a while since we looked at this, so might as well. There we go. So you can see it, and I have to aim right back into it. So this probe is definitely putting things more into context when it comes to the wide field of view. But if I were going over fracture assessment, I always caution people at the flexor tendon insertions, because there's little tubercles on the sides, the mid shaft of the middle metacarpal right here. So this is a good place to practice not getting faked out by a fracture, because that's not a fracture. That's the insertion of the superficialis layer of your flexor tendons. So you got profundus in the middle, and superficialis dives down to the side. And we're going to go over that in great detail next week. But that's a pitfall to practice. Hey, am I seeing a fracture or not? Does it look like this or not? And then you would go in short axis and see that that's just a ridge of flexor tendon insertion right there. See that ridge? So you're just catching the ridge in one slice, but if you obliquely slice it, then you're going to end up with something that looks like a fracture, and it's not. Good question. And as painful as it sounds, you can also just try to displace the fracture a little bit, make it move, apply a little pressure, because I've seen and heard of many cases where x-ray misses a small fracture, but you can actually get the fracture to move a little bit with ultrasound and document that.
All right. Well, I'm not seeing any other questions, so I think we could probably close this one out before you get too far into the next
really. Into next
the
week.
next webinar.
Already practicing here. Yeah.
All right. Well, thank you so much, everybody, for joining us. You can see on the screen here, this is the this is the schedule for our next parts of the hand webinar series. You can see that the next one is going to be on September 16th, and that's the volar hand that Dan was talking about. And then on September 29th, we have the arthritic hand, and we'll be joined with Dr. Daniel Malone for that one. And then on October 7th, we'll have advanced hand. And you can go ahead and scan the QR code there to get to our webinar series page. I believe just part 2 is up for signups, but part 3 and 4 should be up there shortly as well. So I'd like to thank Daniel so much for this incredibly in-depth look into the hand here. And thank you all for joining us for our introduction to the dorsal hand. Dan, thanks again for joining us. We appreciate you sharing your expertise. And thanks everybody else for joining us today. We'll see you at the next one.
Thanks, everybody.